Now, without further delay, let's begin today's event, sponsored by Maestro Health and hosted by Employee Benefit News and Employee Benefit Advisor. I'd like to introduce your moderator for today, and that is Nancy Reardon, Chief Strategy and Product Officer for Maestro. Nancy, you have the floor.
Thank you, Adam. I appreciate it. I appreciate everyone taking the time on Tuesday to attend this webinar with us. And I think it's a very exciting time because I think it's very rare that you have a broker, a provider, and a lawyer on the same webinar. So let's leverage this expertise as much as we can. So to start off the panel, we have Doug Heatherton. He's the CEO and founder of Health to Business. Doug is a respected and trusted employee benefits visionary with over 15 years of experience in self-funding, captive, population management, and cost containment. Recently, Doug was recognized as a Benefits Pro 2019 Broker of the Year finalist and also featured in the March 2018 issue of Benefits Pro as a face of change. Welcome, Doug. Next up is our provider, Garrett Weldon. He's the VP of Provider Relationships and Clinical Strategy at Health to Business. As a doctor of physical therapy, Garrett joined Health to Business to continue his focus on building care delivery programs with a specialized focus on the strategic partnerships between hospitals and employers. He believes when providers and employers come together in a direct partnership, sustainable programs are created that support the providers in their initiatives and provide a quality, memorable experience for the employee and their dependents. Welcome, Garrett. And finally, we have Scott Bennett, our very own. He's the Vice President of Access Innovation here at Maestro Health. Scott is an attorney, a data analyst, a software developer, and he has years of experience in designing and defending cost containment programs. He has successfully litigated and participated in trials, depositions, and negotiations concerning medical billing disputes among providers, patients, payers, involving reference-based pricing. Welcome, Scott. So today, what we will cover, we have four main topics that we're going to review and pose questions to the panel. First up, it takes a village. Why you shouldn't go it alone and why it's critically important for you to utilize and leverage the expertise that is available to you. Two, it's not just about the money. Look beyond just unit cost savings. Manage your employee health benefits program more holistically. Third, manage the employee benefits journey. Communication and education matters. Make it simple and make it relevant. And lastly, minimize legal conflict. Any change will create bumps in the road. Be prepared and be proactive. So we're going to start with the first one. It takes a village. The one thing that we want you to leave with during this webinar is you just don't want to create your village full of vendors. You want to create your village with a partner who can be an extension of your HR team and of your company. And it's critically important as you take this trip on creating this vision to deliver on your employee benefit strategy to focus on delivering better outcomes at a lower cost. And the first part in this journey is working with your broker. So Doug, from your perspective, why do all these players need to work together? Why are they all important to delivering a cohesive ecosystem?
Thanks, Nancy. That's a great question. You know, I think as a broker, I think you're stuck in the middle a little bit, and so you kind of get a little bit of a perspective of all stakeholders to some degree. And I think maybe my journey's been a little bit different than most. I started as a broker, second generation, 2 decades ago. And it was probably about 10 years ago when I kind of had that realization that things weren't going the right direction. I think we were in the middle of a health reform debate, a healthy recession, and I remember one day having just a kind of like getting punched in the face and having a recognition that I'm never going to be able to retire. And I think what I mean by that is that as I looked at my kids that day, I began to question how they were going to afford health insurance by the time, they were in their middle age. And and then literally how were their kids, my grandchildren, going to be able to afford that? And I think that's kind of what compelled me to begin to question. The goal I set out on originally was, hey, can I solve trend? Go from 9 to 3. That was literally my goal. And quickly that led me out of, I'll say, the fully insured landscape and more into self-funding. And that's really when I think my education began. Quickly, I came across the idea of group health captives, and that's probably what was one of the catalysts for how I look at things and why I look at them the way I do, because about the same time that I became more familiar with the idea of aggregating groups together and allowing them to flex their muscles somewhat, I was also introduced to the idea of reference-based pricing and ultimately, very effective and aggressive cost containment. And so I had the brave idea of developing a group health captive where we required all participants to engage in reference-based pricing through independent third-party administrators. And as I did that, my captive partner somewhat gave me the keys to the car and said, go build it. And as I did that, I chose to go around my market and in essence, put on events, educate the marketplace about what we knew and show the market what we could do for them to see if they were interested in this type of a strategy. Lo and behold, I had a hospital CFO show up to one of my events. And, that could have been an interesting opportunity to say, hey, I prefer that you're not here, recognizing that could be in conflict. But I also was curious as to how maybe we were really impacting this person's facility. And so they participated in the event, and afterwards, I think based on our receptiveness, that hospital facility opened up, and we began to communicate. And for about the better part of 2 years, I would say instead of pointing the finger at one another, we began to recognize the challenges that each of us were facing through an open dialogue. And so I was then introduced to kind of the administration side of hospitals, and together we worked together to create a program in that community whereby which we're offering a zero deductible health plan to those self-funded employers that choose to participate on a direct agreement with this facility. And it's been incredibly successful. But along the way, I also had to learn how the C-suite thinks, what compels and drives them, and then also looking at the human resources department and the unique challenges they faced and how often they're kind of diametrically opposed to the C-suite. And then ultimately, you've got the member, end user, and also patient. And that's somebody that I think is critically important. And along the way, I was a patient in healthcare and had my own perspective. And that is actually when I met Garrett. Garrett was my physician, and through our interactions together, I was much better able to, I'll say, understand the unique challenges that providers faced. And I'd be really interested in hearing from Garrett, his unique story around that as well.
So I'm a clinician, and I recently left, if you will, clinical practice to be engaged in ecosystems and be engaged in processes that I feel are meaningful and sustainable. Because what was interesting, when I was in my clinical world, I was building a private practice. So I was an independent private practice clinician. So that means I'm in charge of, we'll say, the marketing. I'm in charge of the growth strategy. I'm in charge of the accounts receivable. I'm in charge of the contracts with different insurers or networks or PPO arrangements. Like, I'm in charge of this whole ecosystem that I'm participating in. And what was interesting, if you track back to 2005, 2006, so 2005, 2006 is when my profession went to the doctorate level. And in so doing, it positioned us in most insurance plans in a specialist category. And what I started seeing in my practice is, we'll say, co-pays that weren't going towards their deductibles or weren't going towards their max out-of-pocket that were $50, $60, $75, even I've seen $100 copay just to access my services. And what started to happen from a clinical perspective is it felt like every patient that was coming through the door was a financial roulette game I was playing. I had no idea what benefit design was going to be. And more than once, when patients found out what their copay was just to even access my services, they opted out of completing their full care plan. More than once, I had to go back to, say, a referring physician and let them know what the patient chose to do just because of their financial arrangement that they were participating in. And this became something that I will say I realized my practice and the direction I wanted to go and how I wanted to be involved in my community would not be sustainable if each encounter was, we'll say, like this, that built with unknowns and built with a rising copay that wasn't allowing me to, I'll say, invest in my patient and invest in the best outcomes that I could arrive in. So I had to pivot strategies. So what I did is I went into my book of business and I found plan designs that were amenable to the type of care that I was providing, that were structured in such a way that it was advantageous for me to participate with. And I looked across my book of business and went into those and then went one layer deeper and found out which employers were sponsoring these plans. And if it was, we'll say, a local community-based employer, I went and knocked on their door and sat down and talked with the CEO and basically made a presentation of how we could form a quasi-partnership or develop a quasi-program to really let me be a value add to their business, to their employees, to their dependents. And it worked. It was awesome. So now I'm, if you will, a bolt-on to a few employer groups where I'm managing, we'll say, all musculoskeletal initiatives. I'm over in their place of work. I'm delivering services to the CEO as well as to the husband of the CEO and to families, fathers, mothers, and children. Like I'm beginning to have an impact at, we'll say, at least an employer level. And so I'm building my book of business with one employer in particular, and my office manager pulled me aside one day and tells me my new patient is here, which is great, from that same employer group. She's like, Garrett, your new patient's here, but we can't see her. Like, what do you mean we can't see her? And she responds back and she says, hey, like, we don't accept her insurance. Like, what do you mean we don't accept her insurance? Like, I've got people on caseload right now. What do you mean? So I go and talk to the CEO. He says to me, I didn't even think about how this could potentially impact you. I didn't even think how this could potentially impact you. And then he recounted to me what happened. He goes, my broker came in, and at this point in my career, I'm like, broker? Like, what do you mean? Who's a broker? What's a broker? A broker came in with a spreadsheet. I'm like, what do you mean they came in with a spreadsheet? He goes, well, look, what this is, it was my renewal rates for how much my, in essence, benefit plan was going to increase the next year. And I got hit with a 27% renewal increase. And I had no idea what that meant to an employer. And I had no idea the, I'll say, potential consequences that would impact my book of business and my practice that I wasn't even privy to or a part of the conversation. And then he says to me, and look, we had to make a financial decision, and the decision we made was to switch carriers. And it so happened that the carrier they switched to, I was not in network with. I was not on the panel. And so I had now the situation where I had multiple patients on my caseload for whom were now considered out of network. And the program and investment that I was making in this employer group was, in essence, removed from my ability to continue to participate in. And it's just like, what happens to a provider when that occurs? What happens to a practice when something like that occurs? And for me, again, I had to, in essence, go to each of these patients and talk with them. And the end result was that ultimately I had to discharge many of them from my services. And again, this brought me to a position where it's like, man, I'm trying to engage. I'm trying to create and develop something that's meaningful, and we'll say even to my community, and that's sustainable to me. And it was during this time that I ultimately ended up having Doug as a patient. And Doug started talking to me about some of the stuff he was working on. And I remember sitting there, as we're sitting there on the plinth and I'm working with him, he was telling me about how he was, in essence, removing employers from traditional PPO or network arrangements and positioning them in a place where they were flexible enough to once again engage with, if there were willing providers, create something together. I was like, wait, say that again? He's like, look, I'm positioning employers in a position where they're flexible enough to engage with you directly if it was something that you felt was meaningful. And that's developed my thoughts to the point where my initial proposition to Doug was, tell me who your clients are. That's exactly what I want. That's exactly who I would love to build my practice around, are those type of employers that are looking to engage and are flexible enough to do so. And I didn't fully understand what that meant. But in talking with Doug, he ultimately said, hey, look, if you see the advantages of having employers structured like this from a practice level, that it would let you engage with them more meaningfully, that it would let you work with them in different fashions than you've previously not, in ways you haven't been able to, why don't you come help me build it? And that's not what I intended. But over the months that we were talking, ultimately I did. I made the decision to leave clinical practice, to come help, if you will, build these ecosystems that I believe give a better experience, again, if positioned correctly, not only to the employer, not only to the patient, but also to the provider. And it's that, I'll say, community-based ecosystem that ultimately now we at Health to Business are working to create, something that is sustainable and meaningful for the employer, for the provider, and then can provide a great experience to the employee and their dependents.
That's great, Garrett. Thank you so much. I think what we have learned from hearing from Doug and Garrett is that disrupting the status quo will take a village, and it takes that village all rowing in the same direction towards the same goal. And that if you want to realize the benefits of the changes that you're making in your employee health and benefit plan, it's important to make sure that you have all of the stakeholders, the community involved in that change, because you're kind of all in it together. So now you have this stakeholders, you have this village, now what? It's not just about the money. This village needs to exist and function seamlessly to deliver better outcomes at a lower cost. In order to do that, you just can't focus on unit costs, and you just can't focus on utilization. It's critically important that you look at the overall cost of your program, which is a function of both. So as you think about some of the innovative solutions that are out there in the marketplace that you hear about today, direct primary care, bundled service, reference-based pricing, the list is on your screen. It means something to one person, but together, if done correctly, can deliver an effective employee health and benefits program. And also, if done together, meaning don't just focus on unit cost with reference-based pricing, marry it with other things that are going to manage the utilization, look at the outcomes, and direct your employees to high-quality, cost-effective providers. So, Doug, start off with you first. Based on your experience and what you've seen in the marketplace, what stands out to you as strategies that help employers with their plans to control their costs, to deliver that holy grail, if you will, better outcomes at a lower cost?
Yeah, I wish there was just one solution to all of that, right? And I think if you look on the list on the prior screen, it kind of sums it up that there's not a one-size-fits-all type solution. And so I think you have to be extremely proactive in identifying for your community what the challenges are, right? And even community, that can be loosely defined. Often we think about that's the city we live in, but from an employer's perspective, if you've got a national base of employees across most states, well, the whole country becomes your community. And I think that's what it takes is an effective proactive approach to first become educated on what some of the opportunities are that are out there, what solutions are there, the best practices, and then to make sure that as you deploy those, you do them with a vision in mind. And I think that that's sometimes where we get off track, is that we don't focus on having a vision, and instead we just start slapping things in with an expectation that it's going to work. And I think it takes all stakeholders coming together, working at the table together, to be able to look at these solutions to say, okay, what may potentially work for us? I know as a patient with Garrett, I had an interesting experience, and I began to learn from him some of the challenges that he faced. But I always looked at it and said, well, healthcare seems to be getting worse in a way, and our visits with the doctors are less and less. And all of a sudden, we're having an opportunity to reshape plan design through, things like reference-based pricing and direct primary care. And I think it really opens up the options and possibilities for a health plan, both from a cost containment standpoint, but more importantly, the experience of both the member and the patient, and then how that experience also impacts, I'll say, stakeholders and ultimately providers as well.
So it's like, yes, you see the wave of, we'll say, interest in the direct primary care movement. And I thought a lot about this because it's interesting, and I boil it down and I say, what is it that is driving this, that is making people once again interested in it? And I think, as far as I can tell, the lowest, the deepest level I can take it is responsibility. You once again have a group of clinicians, or a clinical group, that is willing to shoulder responsibility for a given population or a given group of people. And that, it's like, yes, that's what we're trying to create, but take it to the whole community, the whole level of providers. So I posted a blog on May 7th on the Maestro Health blog, and I talked about this idea of what would happen if we had providers and employers at the same table talking. What would happen if we both mutually were trying to invest in each other for the benefits of our ultimately employees? And so one of the things that I've seen that's meaningful out in the marketplace is when employers work to improve their plan design to value the providers that are taking care of their population, and then let the providers know that this was a conscious decision to do such. It has an impact from a community-based employer to say, I value you, and I'm going to invest in you so that you can take good care of my employees. So there's an example of one of the things I see happening in the marketplace, Nancy.
Thanks, Garrett. The other thing that we've been hearing a lot out in the marketplace is about bundled surgeries. Doug, what have you seen?
Yeah, so, I think it's interesting. As somebody who has spent a fair amount of time in reference-based pricing, you're constantly looking for kind of what's that solution? How do you mitigate the noise? Because, the financial side of the house is motivated to continue to move forward, but then you've got the human resources side of a plan that's in essence kind of stuck in the middle between the financial motivations and then I'll say the pain that ultimately the end users, the employees and patients are going through. And so, again, anything we can find, I always say reference-based pricing, the option of last resort. What can we do in the meantime? And I think bundled procedures has been one of these advents into the industry that I think is profound for a couple of reasons. One, it's really starting to bring together the idea of consumerism within healthcare. And often we're discussing elective procedures that may be more expensive. And so the idea of being able to redirect care to high quality, known, low cost seems to make a lot of sense. But I think in practical application, we learned that more times than not, it doesn't work. And the reality is it's just the idea of traveling. And it's not so much the burden of traveling itself, but it's everything else that's going on in that person's life, where it's just not conducive to get up and leave. And yet often if we look in our own communities, we begin to recognize we have some fantastic providers there with us already. And it's maybe not necessary to instantly get up and run away to the next city or the next state to go get the best care, but often healthcare and fantastic, high quality, high outcome healthcare is right there in our own communities. And I think what we need to do is just be more willing to engage on a direct basis, and I'll say be less dependent on maybe national-based networks that look at healthcare as a one-size-fits-all instead of something that should be, really a very personal experience to each of us at the end of the day.
Absolutely. I couldn't agree more. The other two areas that we wanted to address, and I'm going to focus these to Scott, our resident reference-based pricing, because it is out in the marketplace. Scott, can you talk a little bit about reference-based pricing arrangements?
Sure. Just briefly about reference-based pricing. It's when a plan sets the benefit level and also sets the reimbursement methodology. So it does have some real advantages in that when you have a predictable and easy to administer benefit payment, that actually helps for how much the plan spends. And it's got high savings, and it's easy to administer, like I said, but it does create some confusion among the members and also among providers. So that's one piece when you bring in this new methodology, this new format that's not like a traditional network, is trying to combat this confusion that exists inside of the care delivery path and payment. So Doug, maybe you could talk for a minute about ways that you're able to take some of that confusion and engage groups and really educate them, kind of the engagement portion of it, the education piece of it, to make sure everyone's on at least close to on the same page when these things start out or during the implementation.
Yeah, I think you mentioned it there, Scott. It's engagement, it's education, it's communication, and repeat. There's a variety of ways that we can communicate with members, and in a high engagement solution, similar to reference-based pricing, any other type of advanced cost containment, you're almost always going to find that you're in an unbundled TPA world, and that can be a little bit foreign for members and even stakeholders helping to manage the plan. And so it's critically important that we look at education, communication and engagement on a very robust manner where, what are the different ways that we can communicate with employees, making them aware of the challenges that the plan faces, even then identifying those providers in a market space that are, we'll say, behaving, even those that have communicated that they're agreeable with our strategies and welcome those lives and those plan members to come receive services there. It's critically important that we get that information out to the members. But I also think it's critically important that we do it in a positive way. Often I see, brokers or other various stakeholders gravitate towards kind of more of a negative tone, in particular against providers. And I think if you sit down with a provider, you'll find out they're just as frustrated as we are. And so what we do often is educate the members to say, don't be afraid to have a conversation with your provider about this as well. And we invite them to the table to have a conversation with us so that we can ultimately have a better care continuum for everybody at the end of the day. We do the same thing at the HR level in prepping them on an annualized basis, but then also on a day-to-day basis from an operational standpoint, so that they feel as if they are equipped to advocate on behalf of the members. And obviously the TPA is likely the most critical component of this. It really does require a special TPA to manage a reference-based pricing, high-performance cost containment plan effectively.
Thanks, Doug. So you now have created your village of stakeholders and partners. You've now created an innovative plan design for your employee health and benefits program. Now, all of this doesn't work unless you've designed an effective communication and education program for the employees who are expected to use it. So it's important to understand how to drive each of these components that make up the employee journey to make sure that you're engaging them before they become a consumer of healthcare. It's critically important to engage members before they start consuming healthcare. And as you can see from the study on this page, 62% feel that their employer doesn't serve as a resource for their health-related questions. And that is critically important if you're going to be putting in an innovative plan design that expects stronger engagement and stronger influence from the employee before they become a consumer of healthcare. And to remember that consumer communication and education is just not enough anymore. We are all fighting for bandwidth from our personal lives, from our work lives. So for me, I think we need to start thinking about communication more from a marketing term, because you have to be able to get that employee to read that email, pick up that paper, and take some action. So Doug, from your perspective, what are some of those innovative strategies that you've seen that helps employees understand and utilize the benefits that are available to them as they find they're healthy?
Yeah, I think that I've seen a variety of strategies out there that I think many are effective. Again, you've got to have a robust communication strategy. And I think that at the end of the day, this can only be accomplished with a very robust TPA partner. And I know I've kind of stressed that already, but when we think about communicating and setting up, customized programs, engaging members, and then being proactive to advocate on their behalf, if you think about I know we use the word status quo to kind of describe, the environment that most employers are in today, but if you think about that, that's probably 98% of us are participating in one of those programs. And so when you look at the statistics, I don't think it surprises me that there's a high level of dissatisfaction. I recently was in a forum where a president of a Fortune 400 stop-loss vendor shared with us that just if an employer moves from an ASO arrangement to an independent third-party administrator, don't even change the network and leave everything else the same, that could be worth as much as 15-point credit in your stop-loss. And that, to me, was astounding. I think what that goes to show is that the capabilities of an independent third-party administrator run circles around the traditional ASO model. And I think it's because it is of the engagement, the opportunity to advocate on behalf of a member, to hold their hand through the process. I think that's what's lacking, because at the end of the day, when we can sit here as professionals and discuss this, but the moment we all become patients of healthcare, we are nothing but victims at that point. All the knowledge in the world doesn't seem to matter all of a sudden. And so for me, I want to make sure that I've got a robust, high-performing, highly compassionate TPA on my client side.
Couldn't agree more. Scott, from your perspective, when you think about the employee benefits journey and you think about a lot of the press that reference-based pricing is getting today, what are some of the things that you've seen when you look at, litigation, plan design, summary plan descriptions that could be helpful for the audience to understand?
Well, I think for members especially, Doug did a great job of mentioning that members truly are, they're at the forefront of this. And so there are ways to make sure that the member understands the revenue cycle better, especially in these more creative and flexible forms of plans, and all the different events in the revenue cycle that can cause a member to commit to something that can be much more costly and maybe not the best outcome. So two key components would be the revenue cycle, and then also generally the care options that are available. I think there's technology now, and there is also a lot of data out there that gives members the ability, especially with these independent TPAs, to identify when they might be signing an admission form that commits them to a balance bill, or when they might be agreeing to a referral or going to a specific provider that ends up costing them a lot more. So being a lot more in tune with that and understanding how to navigate that path, or how to work with someone who knows how to navigate that path, are the two key important pieces. I think it's got to be more from general health to financial health, and then informed consent has to come back into this from a financial perspective too.
Thanks, Scott. So the last piece is minimizing legal conflict. No matter what path you have chosen or have chose, there are going to be bumps in the road. But if you have a mitigation plan in place and you have identified triggers that you can deploy actions against, you can be more proactive than reactive. And, let's call out the elephant in the room, right? Balanced billing. And I think what people don't realize, Scott, is, and I think you do, but balanced billing happens in a network environment too. It's just not contained to reference-based pricing. So from your experience, what advice would you give the audience?
I would say that there are these conflicts that arise, and the conflicts are, sometimes they stem from confusion, sometimes they're intentional, but all of the conflicts around revenue and around payment can occur in a traditional plan and with balance billing, and those start fierce conversations. They start conversations about whether or not the amount is correct, and I think being able to start those conversations, at least initially in some of these plans, creates a much more knowledgeable group and can lead to some better outcomes. I was wondering, Doug, if you could talk about any instances you've experienced, having been a broker with reference-based pricing plans for a while, where you've seen the conflict resolve and turn into something that may be a little better outcome.
Yeah, right. I think the first one was as you're out marketing the idea. We hadn't even started it yet, and having a hospital administrator show up. And I think because we took it as an opportunity to collaborate as opposed to, wag our fingers at one another, it's pretty amazing what we accomplished, right? We've now got a dozen employers in a relatively small market space that have now partnered with a hospital facility and managing probably 80% of their utilization. So from a volume of noise standpoint, we're dealing with a fraction of what we were before, and yet the member is receiving a much better plan design. I also think that, sometimes we have to look at why are we having the noise, and it could just be lack of communication often. And so I think if we can better have the employers, convey to then the provider community why it is they're making the decisions they are, I think we'd be amazed at how smart and willful the provider community is to be part of the solution ultimately. And, that even bared out, in my experience with Garrett, as I began to learn why they do some of the things they do, that we then changed plan design as an incentive to have providers partner with us. And so we proactively communicate that to providers on a regular basis, the benefits of a direct contract and what that means for both them and the patient, and ultimately, again, leads to a better care experience and less noise.
Right. Definitely. And then the last piece that I was going to talk about from a conflict perspective, and not belabor too much, but there are points where you hit no bargaining range, and the conflict can't be resolved. And so you have to have the kind of partner that can at least work the needle back towards a negotiation or review. And the key components for that are you want the ability to understand the medical billing and the terminology for reference-based pricing or the reimbursement methodology. You want someone who can take technology and harness all of the data that's available now to show some of the evidence as to whether or not the payment is reasonable in a community perspective, not just the bill, but the community. And then lastly, that legal framework, that regulatory framework to know what the rights are that are in question or being challenged at the time that there is a conflict about reimbursement is really important. It gives you the ability to have that structured conversation that follows from the continuum of let's work together to figure out whether or not this billing is correct and identify issues there. Then let's work together to figure out whether or not this billing is reasonable and have the argument there. And then let's talk about whether or not this is an aggression from either a payer or a provider side that needs to be resolved through a formal process. And that would be if there are issues with underpayment or if there are issues with abusive collections. So I think it's important to see both sides in order to best resolve the conflict, and that's a good framework to use. The idea of understanding the billing, understanding the technology and the community and data, and then understanding the legal framework.
Thanks, Scott. So as you can see, there are many stakeholders that make up this ecosystem, and everyone has a critical role, from the employer, from the broker, the provider, and that could be a physician and a hospital or a small outpatient facility, the employee, the TPA. Everyone has a role, and it should be transparent and clear what everyone's expectations are. And at the end of the day, what does success mean for that employer and the employees? And everyone's kind of rowing in the same direction. If you haven't gotten a chance, I would recommend that you utilize the website that we have made available called GameChangerHR.com and look for the resources. We have put together additional resources that can expand on what we have discussed today, and I would recommend all of you to leverage those resources to strengthen your knowledge and approach in breaking the status quo because we're not going to be able to break it unless we're all grabbing that end and cracking it. So I'm going to move in. We got some great questions from those that attended today, and I'm going to start with the first one. Garrett, I'm going to start with you, but Doug would appreciate your perspective as well. So Garrett, the question is, how do you help providers get comfortable with taking reference-based pricing instead of their traditional fee-for-service?
This is an interesting journey with a variety of providers. So I guess my first thoughts on this, or some things to consider, is what type of provider are you talking with? And that's important to know. Is it a hospital system? Is it an independent provider? Is it a network of physicians? Who are you engaging with? And then here's the principle that I will leave on this, and it could definitely be developed further. But if you go back to my experience, in no time did Doug present this to me as a cost containment solution, right? For me, what it was an ability to, I will say, engage with my patient population differently, creatively, innovatively, to actually be able to have a degree of responsibility for a population that wasn't thwarted or impeded by a traditional PPO or network. So again, this could be developed deeply, but what I've experienced in myself and talking to providers now and hospital systems even across the nation is starting first with the flexibility it creates for the employer to do something different, to do something that's more meaningful and sustainable to all stakeholders.
Yeah, and I think from a broker's perspective, and one of the reasons why Garrett mentions that I never really brought up it as necessarily a cost containment strategy was, back to this idea that just moving away from an ASO is worth some savings. Well, just moving away from the network is worth probably another 30% savings. There's those that argue out there that there's 35% waste in healthcare, and I think by moving to a more independent platform, that sure it's more work. I think what you do is you're eliminating a lot of the middlemen, and I think that that's where most of the waste and excess expense in healthcare is. And so if you think about that, we're not really asking the provider to take a haircut in their reimbursements. What we're asking them to do is be accountable to what they charge, why they charge it, and what's the expectation on the other end, right? There's so much lacking from consumerism within healthcare, and yet part of that is because the providers don't really know how to generate a consumer-friendly world. And so what we've done is sit down with those providers, primarily facilities, and say, okay, what is a fair reimbursement? What do you need? What are your costs? And we basically have conversations with them similar to how businesses interact. And at the end of the day, you'd find that they're very willing to engage in those types of honest conversations for the betterment of their community.
Yeah, I agree. And I think for some facilities, I'm not sure that they have the expertise in-house to really understand, their revenue model. And I think when you deal with innovative TPAs who have taken all of this data and put it in a visual description that helps them understand not only how they compete on cost, but how they compete on quality within that certain community, also helps the conversation as well. So it's also about informing them and providing them good information. Next question, I'm going to go to you, Doug. So in the beginning, when you talked about employers, there are many stakeholders within the employer. There's HR, and then there's the C-suite. What specific steps or language can you implement to get them talking and kind of being on the same page when you think about these innovative strategies?
Yeah, I found it on several occasions where I'd walk into a meeting and you would have, let's say the owner or CEO, CFO, COO, but it was like HR was missing from the room. And I would often ask, well, why aren't they here? We'll bring them in later. And I sit there and I question that immediately because I'm thinking, wait a minute, this is the person that 365 days a year is charged with managing this plan, being an advocate for your workforce, and yet 3 people on several days a year are going to know enough of what's going on a daily basis to make an effective decision around what's best for that population. I questioned that. And so right out of the gates, I would own it with employers, and I would walk into the room and I would say, quite honestly, I really don't believe in what you're doing today. And so there's no risk of me walking in here trying to ask you to sign over a BOR. So whether that's disruptive to your relationship or HR's doesn't really matter. The reality is this is an education. And what I do is I focus on teaching these employers why it is that maybe their plan isn't working for them today. We discussed the pain and suffering they've gone through for the last 20 years trying to solve this problem. And at some point in time, we have to just, lay our cards on the table and say, if you want to continue behaving the way you are, well, that's the definition of insanity, and nothing's ever going to get resolved here. So unless all stakeholders are at the table, understanding what the challenges are and what the opportunities that are being presented to us, and each of us as stakeholders having an opportunity to ask our questions and to imagine what if and how would that impact, right, my realm, my scope, well, then you get full buy-in. And when you do it that way and you have an employer that finally chooses to make that leap to partner with a fantastic TPA, be reference-based priced, be self-funded, they're all in it together, and it's a unified effort. And what you will find is it is then communicated to the employees why they're doing it and then more effectively managed as well. It's a much better outcome.
Yeah, it certainly is. Garrett, a question from you. Though, Doug, I think in your experience in direct contracting, you may be able to provide an opinion. So, Garrett, what are your thoughts on outcome-based model for providers to hold them accountable for the outcomes of care that they give?
Let me start this like as an umbrella. Overall, I think it's great. It's absolutely phenomenal. If nothing, I, as a provider, like to be able to, if you will, publicly show the work that I'm doing. In essence, it lets me, I like it. But I think it's important to also understand the limitations. I've seen outcome measures used in a few different fashions, and one might just be internally to filter and direct care. It's like perfect. But if you're going to start engaging with providers, you may need to understand a little bit more about how outcome measures are derived. So typically, outcome measures, it's from a research entity, if you will, and they're studying to see if this given measure can predict or indicate or show a certain hypothesis. And so what it means is that they have to basically have criteria to say, in this study, certain people can participate and certain people cannot participate. So let me give you an example of what that means. In my clinic, we were measuring ourselves via a few outcome measures. And I had a patient come in that had musculoskeletal, we'll just say acute low back pain. But he also had a history of both sides of his legs, I will say clogging of the main artery that supplies blood down into the leg, as well as diabetes. So for that given individual, the associated outcome measure that we were using would not be appropriate. And I guess my thoughts on that is don't make that error. Don't think that just every outcome measure is applicable to every situation, but instead go in and talk with your providers. If you're looking on the Medicare star ratings and your hospital's at a 2 or a 3 star, go in and talk to them. Ask what's working, what's not working, what they're struggling with, if you will, to see if you can be as much of a solution to their potential outcome-based measurements as you can be. So again, overall, I like it. But remember what the limitations are of each outcome-based measurement, and engage your provider community if the outcomes aren't what you think they should be.
And I would agree with Garrett. I think you have to, take it subjectively. I recall a couple of years ago walking into it wasn't a very large market, but I would say this was the tertiary facility for that market, and having a conversation with the CEO of the hospital about, in essence, their quality scores. And I visibly watched this CEO get red in the face and go on about a 10-minute rant about how frustrated he was with that, and explain to me that there was a hospital literally across the street that didn't have an emergency room. And because of that, even if you got sepsis at their facility, didn't matter. You were going to come over to his, and he was going to have to report it. And so I think that we have to recognize that all providers are not equal. And so from a philosophical standpoint, understanding that there is no one go-to resource for what really determines quality within healthcare, I think that we tend to gravitate back towards more of an experience standpoint. First, what is it like to engage with this provider, and are they willing to be part of the solution? But then two, what's the actual experience of care like? And do I feel better about myself when I walk out, more informed, and no longer afraid of healthcare, but now looking at it and saying, I'm a willing participant of healthcare? To me, if we've got, patients that are basically saying, I'm ready to be, successful and healthy, well, then we're probably already halfway down the battle of actually improving healthcare across the board. So we tend to gravitate and focus more on experience.
That's helpful, Doug. Thank you. We're getting quite a few questions on reference-based pricing, so I'm going to try to combine them, and this is going to be for you, Scott. So what are some of the characteristics that people should look for when selecting a reference-based pricing provider?
Oh, sure. I'd be happy to walk through kind of a good standard checklist. I mean, the first component is the ability to execute on the methodologies. I think that's something that should be tested to start, to make sure that they're able to conduct the reference-based pricing. They've got a good understanding. So that's that medical billing understanding and the reimbursement methodology side. So you need to have some expertise there. The next would be the ability to have that reference-based pricing group to have good technology that looks at present data to identify the markets and understand what's going on in the market. So it's important for a reference-based provider to not only know how to, conduct the classic processing for the plan, but to understand the context of what's going on. And then there's a very kind of social and, I would say, customer service side to it, where that reference-based pricing group is also able to communicate what they're doing effectively and rapidly to anyone who has confusion or question, whether it's a provider or a broker or a third-party administrator that they're working with. So that's a very important piece that it's a little bit hard to gauge at first, kind of like in a job interview, but you want to probably make an on-site visit of some form and have some good conversations about the industry with that group to understand whether or not they can explain the concepts of what they're doing well. And then lastly, the risk that it creates is really important. So there needs to be an understanding of the dispute resolution part of reference-based pricing. So what a typical dispute resolution process might look like, how they would resolve disputes if it's just a negotiation, what approach they use for a negotiation. Is it just a bartering where you say, will you take 10% off, will you take 20% off, and then they kick that to you? Or do they have evidence-based negotiations where they look at the actual market and the reasonable value and present some evidence and help to move the needle that way instead of just sort of that zero-sum game of money? And then also, do they have an understanding of different structures and frameworks that exist outside of reference-based pricing that have an effect on hospital systems? Do they have an understanding of the workers' compensation fee schedule in the states where they're operating? Do they know what PIP and auto and damages look like? What do the court cases look like that are collections cases for patients and for other groups? So if you put all that together for a reference-based pricing group, if you take the medical billing and industry understanding, you take the ability to execute and provide good customer service, and then you take that legal background and understanding, you've got a pretty good provider there who can probably, a vendor who can probably work well for you.
Oh, that's great. One other question along these lines, because I think also the unknown makes people afraid and there's a lot of horror stories out there, but typically you hear about the 1% and not the 99%. Mm-hmm. So how often does balance billing issues escalate where you actually need legal support and guidance? And then when it does happen, who do you believe needs more protection, the employee or the employer?
Oh, interesting. So the employer initially. So the first part that may trigger what you would see as legal red flags, which very rarely occur, but when they do occur, is the employer, because it's a challenge to the ERISA plan, and it's a challenge for additional payment and interpretation of the plan. So that's the first part where they would need protection. But then it moves from that to protection for the employee, and that's because the employee may have signed an admission form, or there may be a collection action for the balance, and that's that balance billing piece. And then it kind of circles back where the employee may look to the employer to find out whether or not there's additional monies or coverage. So that's kind of the flow of it. Now, as for when legal cases actually occur, how many balance bills occur, it sometimes is different according to market and hospital systems. There are some very aggressive hospital systems, but that's easy to find out if you look at, for instance, that hospital's litigation practices in uninsured patient collections and what they do. So if you understand the hospital system and the market in the area, whether that group or that market, for instance, New Jersey is a place where hospitals bill relatively high, and there are a lot of out-of-network surgery centers. So that might be a place where there's a lot more of a range of negotiation and high out-of-network bills and maybe some aggressive collection tactics. As for those disputes, we're getting to a point where you have to actually hire a lawyer. I think that doesn't happen as often, and the only gauge I have for that is looking at the federal docket just about every week. There are only 7 cases right now that are concerning reference-based pricing in the federal dockets, and then those probably don't reflect the state dockets and collections, but there just aren't that many instances where it got so bad that attorneys got involved and there was not a decent conversation like Doug and Garrett have talked about, where it was resolved beforehand, sometimes resolved with a better outcome than before the conflict occurred. So it's not as common as you might think, but you definitely want a partner who knows what the environment's like before you go in.
Great, thanks, Scott. I think we have time for one more question. I'm going to throw this to you, Doug. In your opinion, what are the best metrics to measure a medical plan's effectiveness?
Really, I mean, I guess I would look at it and say end user experience, right? If we're taking the member into consideration, recognizing that they're a valued, asset of the organization, if we're not taking their experience and their satisfaction around employee benefits in general as the number one barometer of success, I don't know what else we would look at that point, right? Because if they're dissatisfied, then that's the end. We've lost it already. But once we've began to gain that, then what I look at is sustainability. And so if we've actually produced a result that is positive, it's a good experience for all stakeholders, what is it that's necessary and what are we monitoring to make sure that we can continue to maintain that? And so, I think structure and strategy have a lot more to do with it than monitoring performance after the fact. If we're doing a good job of being proactive, advocating for the members with the mindset that outcomes and experience are first and foremost, then I can almost guarantee you that you will have a stable program because you're focused and all stakeholders are moving in a similar direction. But that's where I would start, is the end user experience and determining that they are satisfied.
Great. I think we're out of time. I'd really like to thank Doug, Garrett, and Scott for participating in our webinar today. Again, please go to the website if you need more information, and we appreciate your time. Have a great rest of the day. Thank you.